Good morning, everyone, and thank you for joining in. I'm Dr. Lakhani, and before I begin, first I'd like to thank Dr. Ashish for inviting me for this talk. So what I'm going to do is, I would change the topic a little. I was asked to talk on the role of insulin in type 2 diabetes, but rather I'm going to talk to you about the mathematics of insulin dosing. That's a topic which is close to my heart, and I'm going to talk a little bit more about it. So just give me a second to share my screen. So like I said, I'm going to talk to you about mathematics of insulin dosing. Here I'm going to tell you some of the formulas that I personally use in clinical practice and which I'm sure which will be very useful to you for initiating and titrating doses of insulin in your practice. Now this entire lecture falls into the realm of what we are trying to develop, that is the computational medicine. Computational medicine is trying to create a medicine which is more precise, which is more accurate, and in which our patients are well served by using algorithms rather than by using our own judgment. So we have already given a few talks on that, but this is one which is in the line with the same principle. So this is the outline of the talk. What I'm going to talk to you about is inpatient use, insulin use in outpatient type 2 diabetes. I'll talk to you about insulin use in outpatient type 1, insulin use in inpatient diabetes in ICU, and insulin use in inpatient diabetes in ward. So when Banting and Best first isolated insulin, the first thing they asked was how much to give. So dose of insulin is very, very important. Also, the dosing of insulin is very unique, as you would have realized. Now, any other medicine is pre-formulated. For example, metformin is formulated in a dose of 500 milligram or 1 gram. Whereas insulin, if you see, can be titrated. So you can give anywhere between 1 unit of insulin to hundreds of units of insulin, depending on your clinical circumstance and depending on the patient's requirement. So that's why it's very, very important to understand how much insulin to give, because the dosing of insulin has to be very precise and has strong implications for clinical practice. So let's first discuss about insulin use in outpatient type 2 diabetes. I'm going to show you some formulas which again would be very useful to your clinical practice. Now the first formula, which is which insulin to use. So you have a patient with type 2 diabetes and you have decided this patient requires insulin. You have two choices. Either you use a premixed insulin or a co-formulation insulin or a basal insulin. Now, which insulin of these to use would depend on this formula. This formula is fasting plasma glucose divided by HbA1c. Now, if you get a value which is less than 20, you should prefer using a premixed insulin. If it's more than equal to 20, you should prefer using a basal insulin. I'll give you an example for the same. For example, let's say your patient has a fasting plasma glucose of 250 and the HbA1c of this patient is, let's say, 10%, right? So when we divide 250 divided by 10, we get a value which is 25. Naturally, 25 is more than 20, so we will prefer using a basal insulin. Let's take another case where the patient's fasting sugar is, let's say, 110, whereas the postprandial sugar is 330, and the HbA1c is again 10. In this case, the ratio of fasting plasma glucose divided by 10 will be 19, which is less than 20, in which case you should prefer using a premix insulin. Now, the logic for this is very simple. The higher the ratio means that there is higher contribution of the fasting sugar to the overall HbA1c, whereas if the ratio is lower, it is suggestive of more of the post-meal glucose which is contributing to the overall HbA1c. So in this scenario, it is very, very useful for us to really calculate this formula and use the right type of insulin in our practice. Now, let's say you decided to start a patient on basal insulin. Now, how much of basal insulin to give? Now, how much of basal insulin to give is dependent on two formulas. One is weight-based formula, which is given by the manufacturer. And second is what is known as a Holman-Turner formula, which comes from their study, which is treat to target study. Let's look at each of these. So first is a very simple weight-based formula. That is, the basal insulin dose should be weight in kg into 0.2. Right? So very simple dose to use. For example, if your patient has a weight of 100 kgs, 100 kgs into 0.2 will be 20 units. Right? So you'll be using 20 units of starting dose of basal insulin. Let's look at another scenario and another formula, which is the Holman and Turner formula. Holman and Turner formula is based on the fact that it's not based on the weight, but rather it is based on the patient's fasting blood sugar. So again, if you take the scenario which we discussed earlier, let's say the patient fasting blood sugar is 250. 250 minus 50 divided by 10 will be the Holman-Turner formula for using basal insulin. So if your fasting sugar was 250, 250 divided by minus 50 divided by 10 will be 200 divided by 10 again, which will, so will be 20 units, right? So this patient again would, let's say patient's fasting sugar was 250, will be starting with 20 units of basal insulin, right? So this is the Holman and Turner formula. Then let's look at how much bolus insulin to give if the patient requires a basal plus therapy. So let's say your patient, you have started on the basal insulin and you have fixed fasting first. And once you have fixed the fasting insulin dose, then after that you need to add a basal plus therapy, right? So in this scenario, for example, you have fixed the fasting, but the HbA1c of the patient is still high. In that scenario, you would prefer using the patient, adding a bolus insulin to this patient, that is a basal plus therapy. So how much of a bolus insulin should you give? And this is where the formula comes, which is very simple: post meal glucose divided by 36. Okay, so let me give you an example of this entire thing. So let's say my patient has a fasting sugar of, let's say, 250. His post meal sugar is, let's say, 420 to start with, right? And HbA1c was somewhere around, let's say, 10, right? It might be more, but let's say. So we started the patient with the, let's say, Holman-Turner formula. So 250 minus 50 divided by 10 is equal to 20 units. So we started the patient on 20 units of basal insulin, right? Now we titrated the basal insulin. Now the patient's fasting sugar is 120, but the post meal sugar is still 360, right? So post lunch sugar, for example, is 360. So we still need to correct this post lunch sugar. So this, to correct this post lunch sugar, we can give a short acting insulin before the lunch. So how will you calculate this dose? So it is 360, that is the post lunch sugar, divided by 36, in which case the value comes to 10, right? So I will be giving this patient a basal insulin, which is might be titrated, let's say, 24 units at bedtime, and before lunch we'll giving a short acting insulin, that is 10 units before lunch, right? So this is what is known as a basal plus therapy, right? Let's look ahead. Now let's look at outpatient type 1 diabetes, how you'll construct the insulin treatment regime and how will you adjust the dose of insulin. So first, a lot of this comes from a study done by Davidson. So Davidson came with the original formula, but then there's a latest study which is published by Davidson. I don't know if it's the same Davidson, but they published something called the AIM study. So the original Davidson formula were published in 1982 and the new one was 2008. That's why I'm not very sure whether it's the same Davidson who published this, because the time gap is pretty large. So the new formulas come from the AIM study. The AIM study, in the end, I'm going to give you a sort of a cheat sheet where which you can download and you can use in your practice, in which I've given the reference for this particular study. So the AIM study looked at ways in which they could modify the Davidson's formula and give a more precise formula for use of insulin in type 1 diabetes. So first, let's talk about total dose of insulin. Okay, so how much total dose of insulin would you give in a patient with type 1 diabetes? Now the total dose of insulin is calculated using 0.52 into weight, right? So again, to simplify, you can just do 0.5 into weight. Okay, so let's take a case scenario where you have a patient with type 1 diabetes who presents for the first time and you want to start a basal bolus insulin regime. Let's say the patient weighs, it's a child who weighs 20 kgs. Okay, so this is a 20 kg child and you want to start an insulin regime for this patient. So all you have to do is 20 into 0.5 will be 10. So this is the 10 units will be the total dose of insulin which this child should receive over 24 hours. Now this total dose is then divided into 50% basal and 50% bolus insulin. Okay, so once again, right, so this child will receive something like a insulin basal. It could be anything, glargine or degludec or whatever. So you start with 5 units, right, because it was total was 10, and then insulin bolus doses, which you will be total will be 5 units. You can round about to 6. So I'll give 2 units before breakfast, 2 units before lunch, and 2 units before dinner. Okay, so this is how you could construct a initial regime using the Davidson formula. Now, there's another way. So I'll first talk about this, right? So this algorithm, right? So initially, when the patient came, we calculated the dose based on the weight, right? Now, because you don't know the clinical situation of that patient, so we just all we know is the weight of the patient, right? So we started the patient on a total dose based on the weight. Based on this, we'll calculate the basal insulin dose. We'll calculate the insulin sensitivity factor and insulin carb ratio. I'll talk to you about this, and then you do keep checking the patient sugars and doing the correctional factors. So you'll get an adjusted total dose of insulin. And this adjusted total dose of insulin, you will readjust the dose of the basal and the ISF and ICR based on this regime. I'll come back to this point again, right? So let's go to the other formulas. Okay, so yes, so this is the outpatient basal dose based on the the total dose of insulin. So like I said, it is 0.47 into total dose of insulin. It is approximately 0.5%, 0.5. So there's 50%, right? So it's very easy. I'll round this to 0.5, right? So 50% is basal, 50% is bolus. Okay. So what we are doing here is that our total basal dose was 10 units, right? So 10 into 0.5, which will be 5 units. So 5 units of basal dose you can give. Again, the initial basal dose can be directly calculated, which is also derived from the same formula, as 0.24 into the weight, which is approximately coming to the same value, right? So we started the patient on 5 units of basal insulin, right? How much bolus insulin to give? Now the bolus insulin dose is a dynamic process. It is based on two things. It is based on the carb counting and the correctional dose of insulin, right? So total bolus dose is bolus dose based on carb counting or correctional. So first day, we'll start the patient on the weight-based dose. For example, we started, like we said, started the patient on 5 units of basal, 2 units of short-acting insulin before breakfast, before lunch, and before dinner. Now, what we'll be doing is that we'll ask the patient to do carb counting and checking the blood sugar, and based on that, we'll be adjusting the dose of insulin. For example, let's look at this. So how do you do a bolus dose based on carb counting, right? I'll give you the example, don't worry, it will be very simple to understand. So let's say the patient is about to consume whatever X number of carbohydrates, divide by insulin to carb ratio. This will give us the bolus insulin dose. For example, let's say, okay, we'll come to this. Insulin to carb ratio is calculated by 500 divided by total daily dose of insulin. Or there is an alternate formula, which is 6.2 into weight divided by total dose of insulin over 24 hours. So this is an alternate formula for calculating the insulin to carb ratio. Okay, so let's look at this, which more about comes to the same, so not to be worried, right? Okay, so let's look at the situation here. Let's say, so our total dose of insulin was 10 units, right? Patient is about to consume, let's say, 50 grams of carbohydrates, right? So first we'll calculate the insulin to carb ratio. So 50 divided by, rule of 500, 500 divided by 10, this will be 50, right? So this is the insulin to carb ratio, you can see here, right? So 500 divided by total dose of insulin. You can alternate calculate using the the other formula. So that is 6.2 into weight was 20 kgs divided by total dose, which was 10 units, right? So 2, so this will be coming to about 12. Okay, so the insulin carb ratio comes to about 12, right? So 12 means that for every 12 grams of carbohydrate, you will be giving 1 unit of insulin. So let's say patient is about to consume, let's make it simple, 48 grams of carbohydrate. So 48 divided by 12 will be 4. So you'll be giving 4 units of bolus insulin before the time where the patient, right? So this is not the entire dose. I'll come to this. Other thing you use is a correctional factor, right? So insulin sensitivity factor, which is 1700 divided by total dose of insulin, right? Now, insulin sensitivity factor gives you the how much 1 unit of insulin, how much glucose will be reduced by 1 unit of insulin. So in the same formula, same equation, if you see, so patient's total dose of insulin was 10. So, right, 1700 divided by 10, that is 170. So 1 unit of insulin, 1 unit will reduce blood sugar by 170. This is a little high because the patient's insulin requirement was a little low, based on the weight. But let's look at the scenario. So let's say the patient's fasting sugar was or pre-lunch sugar was, let's say, 270. Okay. Now our target before lunch was 100. Okay. Patient is about to consume 48 grams of carbohydrate. So based on the earlier calculations, we calculated 4 units of the bolus dose, but patient's blood sugar already is 270. So first it needs to be brought down to 100, right? So the gap is 170, right? And we know that 1 unit of insulin in this case will reduce the blood sugar by 170 based on the current formula. So you have to add 1 more unit. So this will be 5 units, right? So hope this is clear. I'll come back to this point again, right? Then of course you go to the cycle. So initially start with the weight base, then you correct based on the clinical circumstance and go ahead. So let me give this example again, right? So let's say a patient comes, type 1 diabetes patient comes to your OPD, right? Now patient's weight is 20 kgs. Okay. So you have first calculated the total dose of insulin, right? So total dose of insulin comes to 20 divided by 0.5, which will be 10 units. Okay. Now you calculate the total for initial basal dose, which will be half of this. So let's say, let me give just an example. Lantus, you will be giving 5 units. Okay, now we calculate the insulin carb ratio, and so first day you will give 5 units of Lantus, and let's say Nova Rapid, 2 units before breakfast, 2 units before lunch, 2 units before dinner. Now, right, next day you check the patient's sugar, and now the patient's total dose based on whatever correctional factors you had to consider comes to about 20, right? So now the total dose is 20 units instead of 10 units, which was earlier. Right. So how do you calculate the basal dose now? So it is again 0.5 into 20, which will be 10 units. So now from 5 units, you increase the Lantus dose to 10 units. Now you are checking the pre-meal sugars. So let's say your pre-lunch sugar was again, let's say it's a 270. Okay. So you have first insulin carb ratio and insulin sensitivity factor. Insulin carb ratio is 6.2 into weight divided by total dose of insulin. Okay, so let's say 6.2 into weight of this kg child was 20, right? And his total dose was 20 units, right? So this comes to 6.2, approximate this to 6. So this is the thing. Now let's say the child is going to consume 30 grams of carbohydrates. So 30 divided by 6 will be 5. So you'll be giving 5 units of bolus because of the food he's going to eat. And let's say the patient's blood sugar was 270 before the lunch. So you had 1700 divided by total dose, which is coming to about half of 275. So 85, I guess. Yes. Right. So you had the patient's 270 minus 100 was the target divided by ISF, which is 85. So 170 divided by 85, which comes to 2. Right. So you give 5 units plus 2 units, that is total 7 units of short acting insulin, right? So this is how you will give the short acting insulin based on the formula, right? Okay, then let's talk about insulin use in inpatient diabetes. Okay, so in this case, first of all, let's take a situation where the patient is in ICU, right? So let's say the patient comes in the ICU with very high blood sugar. So how do you calculate the insulin infusion rate? So to calculate the insulin infusion rate, we start with 50 units of regular insulin and 50 ml of normal saline and give this by infusion pump, right? Now how much to give will be infusion, so patient's blood sugar divided by 100. For example, let's take a case where the patient comes with the blood sugar of 500 milligram per deciliter, so very high sugar, patient is in ICU, right? So you start 50 units of regular insulin in 50 ml of normal saline and given through infusion pump. Right now, 500 is the sugar, so 500 divided by 100 will be 5. So you'll be starting the patient on 5 units, right, or 5 ml per hour infusion, right? 5 units per hour only, because remember it's 50 units in 50 ml, so 1 unit is in 1 ml. I hope this is clear. Okay, so we'll be starting the patient on 5 ml per hour of insulin dose. Okay, now let's say the patient is on the insulin infusion, you're titrated the, so again, after let's say 1 hour, the patient's blood sugar comes to 300. So reducing the dose to 3 units per hour or 3 ml per hour, right? So this way you can titrate the insulin dose, right? Now, you want to shift the patient from basal bolus insulin to from infusion to basal bolus insulin. Let's say your patient's was in diabetic ketoacidosis, everything got corrected. Now you want to shift the patient to the ward on a subcutaneous insulin infusion, right? So how do you do this? So what you do is you take the last 6-hour infusion requirement and multiply that into 4. This will give you the 24-hour insulin dose. Take 80% of this as the total dose of insulin. 50% of this will be basal and 50% of this will be bolus, right? Let me give you an example. Let's say for the past 6 hours, the patient has been on, let's say 1 ml per hour of infusion, right? For example, right? So 6 hours, the patient will be on 6 units of, will receive 6 units. So 6 into 4 will be 24 units. So patient's total 24-hour requirement is 24 units of insulin. Of this, 50% will be basal. So you'll be giving 12 units of Lantus and 50% will be bolus. It will be total 12 units. This has to be divided into 3 doses: before breakfast, before lunch and before dinner. So 4 units before breakfast, 4 units before lunch and 4 units before dinner. Okay, then let's look at the inpatient use in ward, right? So how do you construct an insulin regime in an inpatient which is admitted to the ward, right? So here we have come with our own formula, which we had published in Indian Journal of Endocrinology and Metabolism. This is based on our study. So I've called it, Lakhani Kumar formula. It's named after me and Dr. Surendra Kumar, right? So this is basal insulin dose is 0.064 plus 0.030 into HbA1c value. So you take the patient's HbA1c. Let's say the patient's HbA1c is 10. Okay, again, I might be a little bad at mathematics. So this will be 0.3 plus 0.064 is equal to 0.364, right? 0.364 is the dose per kg. Let's say the patient weighs 100 kgs. So this will come to about 36 units of insulin, right? So this will be the 36 units of basal insulin. Okay, so yeah, so this is the dose of basal insulin. How much bolus insulin to give? We will give basal insulin. Bolus insulin is equal to the basal insulin. So 36 units of total basal insulin. If you're giving, you'll give 36 units of bolus insulin, which will divide into 3 doses. So this patient, for example, patient with HbA1c of 10 and weight of 100 kgs, what you'll be doing is 36 units of Lantus and 12 units of Nova Rapid before breakfast, 12 units before lunch and 12 units before dinner. Okay, so this is how you'll construct the regime in this inpatient. Okay, so this is the entire lecture. Right now, to make things simple for you, you can get all this formula. You can download. You can use this download link to see all the formula in the presentation, right? And you can then start using it and give me a feedback of all these formulas, right? We also in this given the references for all these formulas, so you can check it out and you can use it in your clinical practice. So I thank you for a patient listening and